Good morning, everyone. You are very welcome to the Enabling Health Literacy Approaches in Communities. The panel will be delighted to receive any questions you may have. Please note the chat feature is not available today. We will be using the Q&A feature that is located at the bottom of your PC or laptop screen. If you are using an iPad, you will find this feature located at the top of your screen. Therefore, any questions you have, please enter them into the Q&A feature. Also, please note, we are in meeting format today and we are delighted to say we have a large number of people registered. We ask you to please remain on mute for the event, and any questions, as we said, please put them in the Q&A feature. Without further ado, I will now hand you over to your host for today, Dave Mitchell, Healthy Ireland Local Government. Thank you.
Thanks very much, Jean, and you're all very welcome to our inaugural webinar this morning. Thank you very much for sparing the time to come and share our findings on health literacy and what we see can contribute to the health literacy question going forward. I'm going to just take you quickly through a few slides here. If you can see that, I can just share from the start. So, yeah, just to let you know, we have our hashtags for social media are hash Healthy Ireland Local Government and hash Enabling Health Literacy. So if anyone wants to tweet or anything during the event, those are the ones to use. The structure of our event today is we begin with our introduction, which we're currently undergoing with myself, and I will also be handing over to Helen Ryan, who is the health lead for adult literacy for all at SOLAS. The second part of this morning's event will be the examination of the work that DCU have done with two of our local development officers in two Sláintecare areas in Mayo and Cabra-Finglas. And presenting there will be Mairead Carney from Mayo County Council, Dr. Hannah Goss from DCU, and Maeve Murray, who led the research at DCU. Following that, then we'll have a breakout session. You will have selected these breakout sessions before when you registered. These are facilitated by Dr. Craig Smith of DCU and Dr. Stephen Behan of DCU. These sessions aren't recorded, and they will commence with 3 5-minute presentations from Bridget Gagan from Westmeath County Council in room 1, Deirdre Gallagher from Kildare Wicklow ETB also in room 1, and Dr. Kat Jenkins of Swansea University in room 1, of LBSU in room 1. In room 2, then we'll have Janice Morrissey from the Irish Heart Foundation, Michelle O'Driscoll and Susan O'Donnell, who's very kindly stood in for Lara, who's not well this morning. And finally, Dr. Emily Merchant in room 2 from Swansea University. So what happens at the end of that, you'll automatically be, that session is not recorded, so it's free and open for people. And then we will move back into the plenary session again with Craig and Stephen very kindly agreeing to feed back the proceedings and discussions that you guys have had in the previous 35 minutes. And following that, then we'll have a panel discussion again with Helen Ryan, Hannah Goss, Emily Marchant, and Vinnie O'Ryan from Healthy Ireland Local Government. So with that, just to remind you, the 2 breakout sessions. I will now hand over to Helen Ryan of the Health Lead for Adult Literacy for All at SOLAS. Thank you.
Thanks, Dave. Lovely to be on this morning with everybody. Just talking, going to introduce a little bit about health literacy and where it's sitting sort of within the Irish policy practice and people context. So my name is Helen Ryan, as Dave mentioned, and I'm the health lead here in the Adult Literacy for Life programme office. So if people hopefully have heard of the Adult Literacy for Life strategy, it's a 10-year government strategy that was published in 2021. After the last general election, it was a commitment in the programme for government. The strategy, when published, needed to sit somewhere. So the structures that were put in place then was that it went to SOLAS, who is our National Further Education and Training Authority. People, again, hopefully are very familiar with. Within the strategy, it is a cross-government, cross-economy and cross-society approach. So this is not new to government. People are probably familiar. They've done this with First Five, indeed, other initiatives trying to cross over. But the challenges around partnership, because literacy isn't just one issue sitting in education. It's in health, it's in financial, it's in digital. There's so many ways of looking at this. And two of the key aims of the strategy really twofold. One is to support adults to improve their literacy, numeracy, and digital literacy skills. And obviously today we're talking about the health literacy aspect of that. And then secondly, because it's not just about people absolutely need those opportunities, but it's also about creating a more literacy aware and a literacy friendly society. So that's the organisational piece that we come across. So the structures that were put in place, there's a national literacy coalition, and again, some of you here today may be sitting on that. It represents nearly 10, 11 government departments sit on it, agencies, libraries. You've got the National Adult Literacy Agency, you've AINTHUS, you have the ETBs, a really key focus, the education training boards. So lots of people of all the agencies and government sit on that group and set out the policies and plans. And then the programme office based here in SOLAS has one director and 5 leads. And I'm one of the leads, which is responsible for health and the health literacy area. Now, just us sitting up in Dublin, isn't going to work as a rolling out policy thing. So one of the key things the strategy had was we needed regional infrastructure, and along came the concept of regional literacy coordinators. So in each of the 16 education and training board areas, there is a regional literacy coordinator. And they are, hopefully many of you here today have met your regional literacy coordinator, or you can look them up and we can certainly send on the names of them, because they're linking very much in locally with libraries, health services, local government, really on the ground, linking in and trying to work out how can we all work together to improve literacy, numeracy and digital literacy skills. And part of that sort of national, the coalition then with the national one, you've got regional literacy coalitions. So that's really, again, 16 of these regional literacy coalitions that, again, health services are very strong and are represented on it and a key focus. And they're setting up their own regional literacy action plans, which have just been actually approved by the cross-government group in the last month. So there's a lot really happening from the national trying to shape stuff and then right down to where the work really happens, which is the local. It's very exciting today to hear about, and to be part of this today about looking at the health literacy approaches within the community, because I do think the community space is really, really important in this. So just a sort of final pieces to talk to you about around the health literacy space then. So what when you look at definitions, and I know this will be coming up, Hannah will be explaining a little bit and you'll be talking about the research, but health literacy in the main for many years was looked at from a personal perspective. So how are our own skills, which is part of that strategy piece I wanted. Let's improve our own reading, writing, numeracy, digital skills to engage with health services effectively. And for many years, that's actually what it focused on, was what's Helen's skills like in doing that. But then it shifted a little bit, because it can't be just about me and my skills, because what am I meeting when I walk in the door? The doctor, the GP, the local government office, even if you take that. And that's where the organisational health literacy piece. And that's really exciting. It's new. There's new research coming down the line through the World Health Organization, and these acronyms drive you bonkers, the MPOL, but there's lots of really exciting stuff on literacy standards, for example, that the National Adult Literacy Agency would have developed. So we're really interested in the organisational health literacy piece. That's really going to take a focus, I think, in the next couple of years. And as I say, that's about being aware of literacy needs, responding sensitively, communicating in plain language, using tools like Teachback. So there's a good bit in the organisational piece that we need to work on. But to me, there is a third arm, and that is the community health literacy, which I call the community health literacy side. And that really is about, so I'm not unwell yet, if you like. Okay, most of us here, hopefully, we're in good shape, we're doing our best. But I am hearing health messages all the time. I'm listening to today I just heard that the flu vaccine on the radio this morning is being extended to anyone over 60 for free. And obviously, we know it's always there for kids from 2 to 17. I think that was last year. But these are health messaging pieces that are coming at us all the time. And so to me, for example, in a really interesting health literacy message on top of that ad, this when I'm working with the HSE, I'd be saying to them, now I don't want a special ad that's just about health literacy, but I want in your flu vaccine ad that you just had, that you're going to put on the radio, one line that says, ask your doctor if you have any questions. Check your doctor. So that is just a very simple message to try and. So I think we have a lot of work, and we could talk a lot today, and I'm sure in the breakout rooms about the power dynamics as well. And a lot of the community work that we need to do with individuals is about empowering them to ask questions, to look for second opinions if they need them, to check in that they know what they're meant to take medication wise, and so on. So to me, the community approach really, as well as around that health promotion, health awareness piece, before any of us are engaging specifically with having something up with us, we need to look at that. So I always see it. I'm naming a third angle as being community health literacy. And so what my role then in here within the Adult Literacy for Life strategy, and what I'm trying to work with, are many different sections and things. So I'm working under the 3 Ps: the policy, the practice, and the people. So starting with the policy, and the Department of Health have set up a health literacy liaison group within the department. That's really positive. I mean, there's health literacy, where is it written? It's written in loads of policy documents, but how does it actually come into reality and an implementation? And the department have, said we're setting up a group, and I sit with them on that group, and we're just working with the researchers in the Department of Health, the policy makers, different groups. So we're trying to really support them and look at doing a health literacy policy toolkit. We're writing that with the department, and then there'll be health literacy research coming out. So looking at it from that policy side and making sure it's written there and it's being done. But policy, I like it, but it can sit on a shelf. I'm really very much into practice. So let's move into practice. What do we need? So been working and speaking to a lot of healthcare professionals over the last year that I've been in this role, and they're saying they need things like they need training in health literacy. So we're working on a short e-learning course. I'm talking to the HSE National Communications Programme, because they're already doing brilliant work, and I don't want another programme, but I would like health literacy in with I think what they do, actually, a lot of that stuff is health literacy, just mightn't be named like that. So again, working with the HSE around training of staff, going to have to begin working with academics, really interesting space, medical schools, undergraduates. There's no mandatory health literacy module in an undergraduate course. So, lots of potential there around the practice side. But plain language keeps coming up. So a lot of the time we've been hearing things are not as clear as they could be, but we need skills. We need to, please help us write clearly and plainly. So again, we've been plain language project. We're training some about 40 staff in total, some of which are healthcare. We're doing another e-learning course on plain language, and we are looking at an Irish course itself as well. So lots of bits. And then working as well then on, there's a health literacy month in October. So hopefully you'll see some stuff on that again with the HSE and different focus and community groups and whatever. We'll try and work and promote health literacy over the month of October. It's an international month that's there. And then finally, the people piece, which I think is what we're all today really interested in, this enabling health literacy approaches in the community. That's the really key piece. And in the people, we need to be supporting people to improve their health literacy skills, their confidence, and how can that be done? So in the national perspective, we had a 1.25 million euro fund, our collaboration and innovation fund we gave out earlier this year. Hopefully that will be there next year again. So conversations today can begin to flow, and you can come back to me and we can link you in with your regional literacy coordinators to maybe access some of that funding for health literacy work next year. But there is some really good, and you'll hear one today. Deirdre from Wicklow will be on today to talk in one of the breakout rooms about that. But what can we put on locally? What needs, what are the infrastructures, what's the training? And Bridget is on as well talking about what they did in Westmeath. So there's lots of really good stuff. I think part of what I'll be trying to do and support people is, can we all know what's happening together and share that? So another key piece that came up was they'd like a space that all health literacy stuff in Ireland is on, whether that's a website and a space. So I would be looking at that as well. And I mentioned the messaging, and then also champions. Like, nothing beats hearing from lived experience on two sides, from the person who's engaging, as in the patient's perspective. But I really also feel we need to hear from the GP and the doctor perspective as well, because we've a lot of, I'll leave you with this. We were on recently on a HSE call, and we were talking about quality and patient safety, you know, and one of the issues that's coming up for people is everyone's time poor. We appreciate that, but you know, going in to deal with your GP, for example, and only being able to offer one symptom, or I'm only dealing with one thing today, Ellen, and I've three things written down. You know, when I tell you the first thing is, well, I've headaches, and I don't get to express the other two, which might be a bit of chest pain, you know, or my breathing, and the third one maybe I have irritable bowel, whatever it may be. You know, we need ways and mechanisms to work and hear the really good, because there is really good practice happening out there in the health service. I know that, and we're trying to work and get that even better. But on the patient side, then we need that empowering piece, meeting the good practice, and where there is not so good practice, trying to work and do that. So that's the three sort of ways I'm working at: is the policy piece, the practice piece, and the people. So really excited today to listen to what's happened, the research coming up, and also the breakout rooms, and obviously the panel at the end, and if anyone has any questions. So thank Dave and Sláintecare Healthy Communities for the opportunity to just share with you sort of the bigger health literacy piece. And as I say, look, we'll talk later on at the panel. So thanks for that.
Thanks very much, Helen. It's great to hear that the health literacy has been looked at from policy practice, and from, most importantly, at the ground level from people. Now moving on to the body of work that DCU and our two local development officers in Mayo and Cabra Finglas did. Just some of you may not be aware of Sláintecare Healthy Communities and how it and where it operates. So just by way of introduction, I'll just do a quick run through that. Just bear with me a second. So it's a Department of Health initiative, which is part of the Sláintecare agenda, but it actually operates through local authorities, and there are 19 identified communities within the 31 local authorities. It only covers actually 14. The others were not in the high enough in the provision rates to qualify. But the department funds the 19 local development officers across these 14 designated areas in the 14 designated local authorities. And these people work on the ground in the community. So they're very much people focused, and they know the communities. They work with the HSE and all the other government agencies, and they work with people like Helen's ETPs and Solace and those other bodies as well that we've heard from so far. But they work with quite a few, quite with almost anybody that can bring any value to their community. They'll work with. So now I'll just hand over to Mairead, Mairead Carney, who's the local development officer in Mayo. Mairead is going to set the scene in terms of the two communities where we did the research. They're very different in terms of urban and rural, and I think it's quite important that you understand that the context before Maeve and Hannah take forward a more detailed view of what the research showed. So without further ado, I'll hand over to Mairead. Thank you.
Thanks very much, Dave. I will just share my screen now. 1 minute. Oh. 1 second, here we go. There we go. Hi, everybody. My name is Mairead Carney. I am the Local Development Officer for Mayo County Council, and with my colleague Talent, who unfortunately isn't here today, we've worked with DCU on the health literacy report. So my job today is just to give you a basic overview of the participant communities in Mayo, which were Mayo and Cabra Finglas, Dublin City Council. So what we're looking at is, from a local authority point of view, we're taking a place-based approach to tackling poor health and well-being outcomes. It is important to know the conditions in which we are born, grow, work, live and age are known as the social determinants of health. The World Health Organization research shows that the social determinants of health can be more important then healthcare and lifestyle choices in influencing health. Social determinants of health account for between 30 and 55% of health outcomes. So addressing these determinants appropriately is fundamental for improving health and long-standing inequalities in health. So we took a community development perspective within our role in the local authority, looking at engaging communities, individuals, families, organisations, stakeholders, understanding the community, the multiple realities that people live in, what their successes are, barriers to engaging with services, education, all of that, and creating opportunities, as Dave said, for collaboration as well. So who were the communities involved? We have an urban and a rural divide community. So you had Finglas, Cabra, Dublin City, and Northwest Mayo, Erris and Achill. These communities were classified as extremely disadvantaged, identified by the bright red there, particularly in Finglas, Cabra, and very disadvantaged, which is highlighted within the deep orange there. Mayo is predominantly a rural community with 71% of its population living in small towns. So the map on the right-hand side of your screen shows the Sláintecare area of Mayo, which is the size of County Louth in comparison to the small urban environment within the Finglas Cabra. The highest population of our rural town is, our biggest town is Balmullet, which is a population of just under 1,200 people. And then we have smaller community nested around there of down to 79 communities. This offers even bigger challenges in delivering services and particularly equity of services. So there are many similarities, but there are many differences. Access to transport. Within the Mayo region, there is very limited access to transport. Within an urban environment, that is not as big an issue. In Mayo, in the Sláintecare area, it takes an hour and a half to get to your local A&E department. So even getting involved in services, getting access to services is even more difficult in that area. On some of the work I was doing, a lot of the communities in Carrotide would not even have access to good drinking water. So all of these kind of build together to create communities that are classified as disadvantaged or deprived. So looking at these specifically, I've just taken the public deprivation index just to show where we are compared to the national average and why we were deemed Sláintecare areas. Unemployment in the national average at the minute is 8%, whereas within Mayo Sláintecare areas, females it's up on 17%, and males' unemployment rates are up on 20%. In Finglas for females, it's up on 13%, and for males, it's up on 19%. Access to third level education, attaining third level education at a national average is 35%. But in the Sláintecare Mayo area, it is only 25% and is even further reduced in the Finglas area to 17%. The lone parenting national rate is 17%. In Mayo, that goes up to 35%, and in Finglas, it goes up to 48%. And there are two areas in Mayo where the lone parenting area goes above 50%. This is huge impact on people's ability to engage with services, manage their health, etc. There are other indicators that are particularly pertinent to Mayo, and that would be our high age dependency rate, with an age dependency rate of over 63%, with a national average of 53%. So that has an impact on our communities and how we work with our communities. And again, because of our older population, the amount of individuals attaining primary school education or secondary school education is much higher than at the national average, with over 30% in that cohort. Because we took a community development approach, that's the data, but underneath that data, as Helen said, is people. They're complex, the communities are complex. We know there's an urban-rural kind of difference, but some of the key things that were coming out for individuals alongside low health literacy, going into groups and hearing people falling because they weren't able to take their medication properly, because they didn't understand it. started this conversation, and that would have been mirrored in Dublin City for Talent in some of the groups she was working in with early school leavers, substance misusers. It kind of all layered on top of each other. But these people are also dealing with food insecurity, energy poverty, rural social isolation that leans into higher levels of mental health, higher levels of depression, social isolation, rural isolation due to lack of services within their small communities, lack of transport, or not feeling engaged. Lower education attainment also had a big negative impact on how individuals view themselves and their ability to engage with services, programs, and health programs that we're involved in. So that's how we came to be involved in this particular research, both myself and Talent, and Dr. Hannah Goss and Maeve Murray, as the researchers involved, will take you more in depth into both Mayo and Cabra Finglas. Thank you.
Thanks, Mairead. Yes, delighted to be here this morning, and thank you for kind of giving up your Monday mornings to join us. I am going to give a little bit of the background on the project and how that came about from our side of view, point of view in DCU with that collaboration, before Maeve will go into a little bit of more detail into the specific research outputs. And I will come back on just before 11 o'clock to bring it all together in talking about our co-design workshops. Now, back in around February 2023, I had a tap on the shoulder by Professor Niall Moyna, who had received an email from Talent and Mairead citing their interest in health literacy and speaking to the fact that they wanted to pursue some kind of research project. And I must kind of acknowledge and thank Niall here, because he is a very senior academic, for those of you that don't know him, with a great track record in kind of public dissemination, but recognise that myself and other researchers within our School of Health and Human Performance here in DCU were working in a health literacy space, and more specifically with children and young people, but recognised that this would be something that we would potentially be interested in working and collaborating on. So again, would like to thank Talent and Mairead for taking a little bit of a chance there and working with potentially less senior academic, let's say, but also for a call for academics to keep your website profiles up to date. That's the biggest shop window, I think, for a lot of academics. And I'll let people on the call know, if you're not in academia, that's something that we're notoriously terrible at doing. So trying to find those research collaborations in an organic and meaningful way is really important. The next step in kind of this collaboration was at the paperwork side of things. And for those of you that may not have engaged with a higher education institution before in a research project, I can happily chat about some of the paperwork that goes behind the scenes in terms of research agreements and things like that we learned along the way. But more importantly here, I think, were the work packages and what we went on to. So there you go, Maeve, you can click onto that one for me. Our first work package that we developed within the research team in DCU, but we went to the wider project team within Sláinte Care Healthy Communities to refine, was what we're calling our kind of desk-based research. So like Helen mentioned, there is a history across Ireland of good health literacy practice and research that's gone on, particularly the NALA 2012 report we could kind of point to there as well. We looked to do a number of different reviews there that kind of updated on this report, as well as in parallel our second work package, which was kind of our qualitative piece, which again, as Talent, Mairead and Helen can attest to, it's really important to get those lived experiences and work with people rather than work on or for people. And finally, kind of bringing this all together, kind of a unique aspect of this approach and a different aspect is this final co-design workshop process. So without further ado, I will pass you on to Mairead, who will talk about this, because critically, one of the key pieces here that may have slowed us down at the start, and again, learnings of part of the research project, is the key for recruiting the right people to work in this space. And I'm sure after the next half an hour, you will see that Maeve was absolutely perfect for this role, and we'll be able to talk to you about her input and findings.
Thank you so much, Hannah, and thank you all for your attention this morning. It's a very warm introduction, Hannah. Thank you for that. But again, I do believe, and we work in the space in health literacy, it is very much a team approach, and we can see that from how this project was set about. So as Hannah kindly has introduced, we had different work packages, and we thought it'd be remiss if we didn't just highlight one of the key areas in this work package, which was that international context. So as Helen has kindly already set the scene for us this morning in terms of health literacy and the definitions, What we find in terms of looking more broadly about health literacy, we found that again, it has this multi-dimensional nature, and there's a very different concept within health literacy. And again, as Helen explained, there's a number of different competencies, skills and abilities, as well as these actions. And we found that very much in one of our very initial systematic reviews to very much set the scene in terms of how we can move forward into our more contextual understanding in Ireland. Similar to that, we look to a worldwide sort of approach and how how countries were looking at health literacy and looking at it from a national policy agenda. And what we saw again is that health literacy is most commonly integrated into healthcare policies, but also in other fields and such as education as well. Again, setting the scene of what it is like globally and where we are aligning to certain areas within the global context in that area. We also saw as well about policy level intervention, and we saw different policies, frameworks, action plans, but again, this integration into existing policies within that countrywide concept. So again, we'll not labour too long in those areas, but those sort of set the scene into the Irish context. So again, within the Irish context, what we wanted to do first, before we engage with our communities in, as we've already explained in our two areas, we wanted to look at where health literacy is as a state of play in Ireland in 2023-24. So our aim was to look at health literacy research over the last decade, and this was very paramount given that we had our European Health Literacy Survey, and we wanted to look at that in terms of where we are across that 10-year period, and also where we can look towards those recommendations for the future. So to be thorough, as we always are, in terms of our research and rationale, we wanted to look very broadly in terms of all of the data that will be published in that space. So we looked at 7 national databases or electronic databases for research, and we did that over a 3-month period, just when I joined to work on this project with the team. We looked at study focus, type of article, the geographical area of interest, given that we're looking at an all-Ireland approach, an all-island approach. We wanted to look at the time period, who the participants were that were being sampled in that research, the setting, the different types of languages used. We kept that very broad in terms of how we looked at health literacy, and obviously in that Irish context. And what we found is that there was a number of studies published in the last decade. If you can see, we have 551 that we found in our desk-based research that led into a 37 paper review. Now, I'm not going to go into each paper in this detail, but what we can see is that over the last 10 years, there has been a growing trend in how health literacy has been published or reported upon. And I do want to draw your attention just to the impact of COVID-19, and where we've seen that last, some of the more recent findings we can see are driven more so since COVID-19, and whether that has its part to play in that aspect. So again, we can see that health literacy has been very prevalent in the nature of Ireland, in the island of Ireland, and we can see that has been very developed over the last 10 years. What we did find in this research, and we looked across that 37 studies, obviously we saw that multidimensional concept again, and again that interest in health literacy is typical at that multi-level approach. But what we find as a research team is that it's set maybe in these 3 themes or 3 areas or domains. The first area or domain being more of a clinical context, looking at maybe healthcare settings or where health literacy was being looked at those who are accessing healthcare and working with professions and professional healthcare practitioners. We also saw that community aspect, and we used that very broadly in the report in terms of how we looked at more general populations as well as those more specific community populations. And that was looking at how their aims and their objectives were set up within the study. And our third domain we looked at was that educational context piece. And we saw that through schools, higher education, 3rd level education areas, and where those areas had overlapped, maybe again within that community and clinical space. Again, I think just to highlight where we are with when were studies that did report on health literacy measurements, and where there was a sort of assessment of health literacy, given that we haven't had that formal look at that since over the last 10 years. We do see that studies are reporting inadequate or limited health literacy, and we can see again where that is very much representative of nearly 50% of the population, depending on the type of samples that were taken out of those 3 themes, as we can see. So again, just to summarise that first work package, we find that there were few studies that, in the few studies that carried out, there was obviously that where there had been assessment of health literacy, that they were found that would be low or insufficient. We also found that there's this lack of maybe health literacy tools or measurements that were used that are maybe conducive towards a number of studies. And we also find that really the studies were more focused on maybe adult populations and clinical domains. And then it's been more short-term or not sustained enough for long-term research. So we really want to leave on that part with these 5 sort of key outcomes of that systematic review. Again, that we have this area of low health literacy that has been reported on in our studies within those particular samples. And I do want to contextualize that for what those 37 studies we looked at. There also is this no gold standard award of how research is really assessing health literacy in those settings again. So different measurement tools have been used. Again, we have different socio-demographic and socioeconomics factors are very much considered in the contextual understanding of health literacy, and those factors very much are to play and when we look in the Irish context. We again want to highlight that real narrow focus in terms of adult health literacy that has been maybe the focus of the last 10 years, and maybe that into healthcare clinical domain that we've looked at. And also with over the last 10 years, there's been a dominant short-term and medium-term attention on health literacy, potentially without that provision or sustained action and follow-up. So that all set the scene until we moved into our settings in work package 2. So in the second work package, again, leads back to where Mairead spoke about those contextual understanding of health literacy. So the aim of this study was to explore these perceptions of these lived experience and community members in relation to that. And you can see where we're talking about where people are working or where people are living in terms of their community settings. So again, as Dave kindly introduced at the start of the call about Sláintecare Healthy Communities and where we are in those areas. And just to reintroduce that rural demographic, but also the geographical scan and area of that what presents in the rural area of West Mayo. And we're talking about an area that covers Erris Peninsula, right down to Lacken, Newport, and all the way down to Achill. In our Finglas and Cabra Sláintecare area, again, we're talking about an urban demographic, again, within a smaller area of different electoral divisions in terms of Finglas and Cabra and how that makeup is made in terms of the urban demographic. So when we set about connecting and engaging with our community participants, it was really key that we looked and worked very closely with Sláintecare Healthy Communities and the local development officers of what is taking place in those communities. Again, obviously, from not being in those areas, we needed to make sure that we address this in a very appropriate way that would make sure we had positive recruitment in terms of that. So what we looked at is those structures that were in place already. Again, within Mayo, we have a different structure in terms of those community groups, but also we had a very similar mix of those community groups already established in place in Cabra and Finglas. And we can thank Talent and Mairead for their help in terms of identifying and working within those community groups in terms of developing those strong links and partnerships that we're able to work with those community participants in their settings. So just to provide a little bit of a highlight in terms of the research project and how we went about designing this part of the process in this work package. So we did undertake some purpose and sampling and how we did that. And that was really to gain and generate insight. And that was in that reflection of the time span for this piece of research. Again, it was not going to take, we wanted to take it very sharp and sharp to make sure that we were able to engage with those participants in their communities as quickly as we can to be able to work with them in terms of their data insight into health literacy. So we looked at those community networks within Mayo and Finglas Cabra, and we looked at those who had lived experience of health literacy, strengths, needs and issues. And as I highlighted in the previous slide, that was working with those established groups and those that we knew we would be able to connect and pry and send a lot of recruitment out to those areas in those communities. So we looked at service providers and we looked at service users through that formal and informal recruitment process. And again, anybody who's been on a large study like this, we try to connect with as many people as we can. And anybody that could talk to me, we definitely made sure that there was an ear to listen to them. So we're very grateful for those as well. So just to give some information on the participants. So for this study, we had 105 participants engaged and recruited for our data. And the breakdown was 75 of those were female, with 30 of those male, and that probably represents the differences within the communities as well and who we were able to speak to at that time. Just to give a little bit of a breakdown again into the interview breakdown, again, we had 13 focus groups and individuals that made up how we spoke to individuals about their health literacy, strengths, needs and challenges. In that focus group, we had quite large focus groups as well, with a lot of that taking place in person. And again, given the data time point and the restrictions on time, we tried to make that as in person as possible. And that was very much related to where we are in terms of geographical area within both areas. So again, just to provide you with the geographical area of where we collected data and within the West Mayo context, you can see Keene Beach there right up down from Kilpatrick and North. So you can see all of that West Mayo. We tried to connect with as many as possible in that Sláintecare area. Again, it's similar in Finglas and Cabra. You can see everywhere in front of or on top of Dublin Zoo. We tried to keep that as possible as well with connecting with those areas. So just provide some information on our methods. So again, the data is collected over a 4-month period between November and February. And where we use a semi-structured interview guide that was developed by our research team and those who've already met today. And what we wanted to do is make sure this was rigorous, but also relatable to how we were going to speak with individuals about their health literacy needs and challenges. So we made sure that this was very much fit for purpose before we engage with our individuals in our interview. Once interviews were compiled, we also made sure they were anonymised and then they were transcribed and analysed using what we call reflective thematic analysis. And just to provide a little bit of a graphic of how we did that, we looked at codes that were generated in that space of what we saw that in that theme of what was coming through from how people spoke about health literacy challenges and needs and issues. And we used those codes to then generate these themes, and we looked at those themes in terms of where they were related to, either both areas or individual areas, in terms of what we understood as researchers in terms of health literacy and what the participants were saying about that. So what we find in terms of those themes, so a lovely, beautiful graphic, but what this means is that in our thematic map, we saw we wanted to really show how much information and much data we were able to glean and take from our interviews. So we had 5 separate themes that we found that were very much related back to what our participants said in their focus groups. So that was from accessing their healthcare and understanding of healthcare, right through to how they perceived health literacy and how they looked at that as an individual, maybe responsibility as well. So just to go very quickly into this as well. So we found that firstly through interviews that our participants spoke about how they're accessing and using health literacy and how they observed that through very different means. We were interested to see what they found, and a lot of that was related back to the internet and how they access that as well. But also what we found as well that, again, individuals spoke about wanting more transparency, but also that they understood in the information that we're receiving that they knew possibly how to critique some of that information, especially for that term of where they're looking at Dr. Google for that information and that point as well. We also saw that individuals spoke about health literacy changing over time, and also that COVID-19 provided different impacts on health literacy in that way. So again, we have different comments here from our participants where they spoke about COVID-19 in different frameworks. So in terms of COVID-19 and when COVID, my weight went up and how that maybe is related to some of the individuals and how they felt within their context. But also we find that some, also in the rural setting in Mayo, found that people were not dropping in and out as they used to, and where that means maybe speaks to that social health aspect. Into our third theme there, and we understood through the research that individuals spoke about perceiving health literacy as an individual responsibility, and this term of advocating for their own health and the health of other ones. And again, I think Helen spoke to this at the very top of this presentation in terms of health sneaking up onto people, and where we found that some of our individuals spoke to us about really they only engage with healthcare when there was a need to, or where there had been some sort of health issue or challenge. So we said that again, that in terms of advocating, we saw that our participants spoke about having to learn to speak up to doctors, get much better at understanding questions, but also that they're advocating that they're happy to change lifestyles if there's a need to do so. We also have some very stark stories of people who speak about this advocating for their loved ones and how they are working with in terms of their contextual understanding of health literacy. So I've just highlighted this very powerful quote that's taken from one of our interviews. And you can see here where an individual is speaking about their own family member and how they are talking about how there was, you know, a lot of engagement within the healthcare setting where they were advocating for their health in that space as well. So into just our fourth theme again, we had this influences on community influence and health literacy. Again, that idea of family and friends been very key, but also this idea of a good neighbour effect and community health literacy champions. So again, we have this very strong quote coming through about how you're changing people's thoughts and needs and thoughts and ideas about health literacy is through the heart and not necessarily through the head. And again, we have that very contextual report in terms of how people are speaking about how they're working, how they're linking with each other and giving lifts to each other to certain, you know, doctor's appointments and how they're working in those community areas. So again, we have this idea about how they're distributing information to each other, their home life and how they're working together in those areas. Again, we have in our urban demographic where we have young carers coming through and how they are advocating for their parents in terms of that healthcare setting as well. But we also have this idea of how they're looking towards their community and individuals like teachers in the school setting and where they necessarily don't think it's always the place to be in school, that this is where health literacy needs are educated and not met. In our final theme, in terms of health literacy access through a rural and urban infrastructure, we can see that there is very much discussed about how they're understanding, how they're using that infrastructure to explore health literacy in that way. So again, this idea about exercising regularly. But it is in terms of that rural infrastructure, and Mayo in particular, who spoke about this healthcare services and how they're accessing healthcare and how transport and the infrastructure in that rural area has been quite a challenge. So again, you can talk here about this emergency and about the emergency having to travel on the road to get help. You'd be waiting for an ambulance for hours to come and help you. So really just to summarise on these points in particular, and where we lay to on the report is maybe a lot of different outcomes that came from that in-depth work, but in particular, the importance of delivering health literacy education, potentially at a young age. And that's what our participants were really sharing about, that where they wanted to be maybe informed at a younger age, or how they can make the best health choices, and where they talked back about that time frame. They also spoke again, obviously, with that inaccessibility of medical services, whether through the infrastructure, whether through the information, and where they're both was contextualised in terms of the urban or the rural demographic, in terms of such as lack of GP surgeries in the rural area or long waiting times for GP appointment within the urban area. So I think just at that stage, I think I will just highlight where we were in terms of that work package 2. So we had that really in-depth recruitment in terms of rigor and how we worked with our social care areas local development officers and to recruit that. We wanted to use that information in our interviews to then inform from our key findings as we go through into our third and final phase of our work package in terms of our co-design workshops. So I'll hand over now to Hannah, who will take us kindly through the next section. Thank you.
Absolutely, thanks, Maeve. And I'd just like to reiterate, if you have got any questions about the previous 2 work packages there, please do use the Q&A function. We can definitely answer some of those questions now or in the chat there, so that Q&A function being there. The final purpose of the project, the final aim of the work packages, was to bring this all together back to the participants themselves and what we kind of call the stakeholders themselves. So we designed and developed using an already established method called the double diamond design approach to engage with our local stakeholders. We conducted 2 co-design workshops, so one in each of the areas in March back in spring 2024. So just to kind of reiterate that, it's quite an intensive session. We did this across one morning, so we had participants from 10 till 12:30. And what I will say is absolutely key there is to make sure that you have refreshments before and after, because you are taking people's expertise and you're taking people's time. So it's really important that we reflect that in there. We had over 90 different individuals in these workshops. So as well as inviting our previous participants who had been involved and indicated that they wanted to remain involved in from work package 2, we also targeted and purposefully sampled other stakeholders, in particular policy makers, people who are working in NGOs, etc., who are influential in the local community that we thought were important to be there. I'm going to talk you through on the next slide here the double diamond design approach. So this has been used in different healthcare contexts. I've used it in a physical activity and physical literacy setting, and we thought it was really important to bring different groups of people together and with some kind of divergent thinking to go through the process of discovering. So presenting back our key findings that we'd found today, and I'll call those our initial findings from what we found from work package 1 and 2, to identifying what our kind of priority areas were for health literacy action, and to developing and co-developing our recommendations for proposed health literacy actions within this community. This involves a process of people with divergent thinking, but also coming back together for some convergence and thinking. So agreeing on some priority areas, to then potentially getting lost in that thought process again, where we're identifying potential solutions, to hopefully and ultimately coming towards that agreed aims towards the end of the process. This then is broken down into different phases. So primarily, to start the day, we are working in same stakeholder groups. So in the case of this project, those might have included classes from the local ETBs, or it could have involved people from the HSE, all sitting on the same tables. So there would be people with similar experience, a similar kind of power dynamic, working together within different tables to identify those key challenges. And that was based on the previous work that we found, and kind of moving together with people's own experiences and perceptions of that. We then move people to mixed stakeholders groups to identify those prioritized list of challenges and develop potential solutions, before then moving back to these same stakeholder groups, and finally coming to democracy voting style activity. I'm just going to talk a little bit about those different phases and how that worked practically on the day before moving on to our findings. So the first part of the day in our same stakeholder groups, if you just want to pop onto that next slide for me there, Maeve, was really important, the registration process. So as people were joining us on the day, they were welcomed. We gave them a 1-page summary of the findings of the report to date, as well as the option for a 5-page summary of those findings. And we gave people a sticker. And on that sticker, there was their name badge, but it also had their number for their same stakeholder group, which might, for example, be 1, and their mixed stakeholder group, which might be table B. People then knew which table and which group to move around they were going to be moving with, but critically at the start, they were with people that would have had similar experiences to themselves for that divergence part of the thinking. The day started by delivering the information in a slightly different way. So you can see there, we're presenting to the groups the findings that and the different information that they had available on their tables before setting the purpose of the day and the structure of the day within there. On each of those tables, we had a facilitator who was guiding the different groups through the day and the activities. And you can see there in italics some of the questions that those facilitators may have posed. Go on there, onto the second slide. We then got people to move to their mixed stakeholder groups. So they would then be moving to a slightly different table, getting people up, moving around, meeting different people, some of who may be familiar, where we were asking people to prioritise those health literacy challenges. So based on the findings to date, based on those different experiences, and again, there was hopefully that divergence, but ultimately a convergence of thinkings. And again, you can see some of the questions there that facilitators will have asked within that session. We then, after moving through the next phase of getting people to discuss and debate potentially some of the recommended actions, we asked our facilitators to present back those ideas that the groups, we ultimately asked people to come up with a short list of 3. And as you can imagine, there was some repetition across the different tables there. So we did our best to synthesize those and present those back. Identifying, and you can see one of the examples there from table 3C in West Mayo, the 3 suggestions of their priority action areas were around funding, around activities, and around transport. And just to the left of that image there, you can also see our democracy in action. So each individual participant was provided with 3 dot stickers where they chose to vote for their preferred health literacy recommendation. We as a research team then went away to synthesize these together. So in Finglas and Cabra, you can see some of the recommendations that we brought together here, again, based on preferred strategies. So things like infrastructure and resource development. And the second table there will show you the findings from West Mayo. Across both of these groups, despite the different challenges and the unique context within there are similarities in those recommendations, termed slightly differently, but the need for community engagement or community hub or community outreach officer was relevant and prevalent in both of those different settings. You can also see in there again this need for this preventative, early intervention, proactive work to promote health literacy across both of these different communities. The additional descriptions, you can see the nuances and the differences within those different contexts about what people were asking for, but crucially, this process allowed us to identify those similarities and those differences for what was going to work in context. Some reflections, and I can definitely go into more detail on these, and you might see some of these come through in the bigger report, but the similarities and differences that we've already kind of touched upon there. Wanting to close the second diamond, you might have heard it being called this adapted double diamond approach. In an ideal world, I would have loved to have gone back to those participants and presented those final tables, because ultimately we are time bound. We weren't going to keep people for a longer period of time, but that would be closing that second diamond and reflecting back our findings would be really useful. We also found some key information in terms of recruitment. We adopted an online process because it was time bound. Mairead's chuckling here because she was spending a lot of time going through and chasing people on the phone or trying to get people to sign up in a pen and paper format. So that was something giving people time to be aware of the project or be aware of the workshops and come through. And ultimately that kind of hitting us with people who are hardly reached. So we had our participants who were already engaged and then not necessarily reaching everybody that we wanted to. Some of the wider kind of considerations for people working with a higher education institution, the ethics and consent forms. And I put plain language statement there deliberately in italics because there are things that we need to put in there around GDPR and the processing of data, legally binding kind of text that we are required as a higher education to put into. That is not plain language. The power dynamics in those different groups, again, we're talking about people who might be engaging in a literacy class themselves, work with someone who might be working in a charity organisation or who might be working for an NGO. There is a power dynamic there, and the role of the facilitator is key for mediating that. And ultimately, this kind of has to be a starting point. We said this at the end of the co-design workshops, is the recommendations that we have here are not a final list of recommendations. They are a reflection of the people in the room and the findings that we had to date. And ultimately, this is going to be an iterative process to refine these recommendations there as we go through. So ultimately, after kind of finishing the co-design workshops, we were presented and developed this final report, and we will be launching that in autumn 2024, and we'll also be publishing some peer review publications within there. But in terms of a small snapshot, it's a kind of hefty document for those of you that may not have seen it already, but we have provided these table summaries throughout. And critically, what we looked to do after working at a community level was to match these to the World Health Organization's recommendations for health literacy development. So you can see that highlighted in the column there. What's really interesting for us is to seeing how at an international level, what the WHO are recommending and calling for, what could be worked on and what would be useful and meaningful at a community level in those smaller settings, and how that might work as we work through those different processes. So again, reflecting that it's not just an individual responsibility, but we're looking at it at an organisational level as well. And definitely within this report, we're looking to challenge some of those previously held conceptions in relation to health literacy. There again are some kind of key findings that we had throughout this process. So reiterating that contextual understanding is vital. The importance of working in partnership, and not just in terms of developing and looking to monitor and evaluate new interventions, but there is excellent good practice up and down the country in relation to health literacy. And again, just to reiterate Helen's point, that may not explicitly be called health literacy, as kind of Mo spoke to, that term itself may be a little bit of a barrier to the public. That emphasis for education, but also continued development for people already working within this space, and also looking to integrate it. The final couple of points just on this slide to kind of bring healthcare and access to healthcare became a huge topic of conversation with a lot of the individuals that we spoke to throughout the project. And also what kept kind of creeping in was this need to monitor health literacy. And that's not necessarily one size fits all approach. There is a need to monitor health literacy at an individual level and kind of smaller groups, and what's purposeful and meaningful in terms of evaluating there. And that will be different to monitoring health literacy on a community, regional or national level. So just to be aware that there are more creative and innovative approaches that we can look towards evaluating and monitoring health literacy as we move forward. Again, I would like to thank everybody that was involved in this research project. So to Sláintecare Health Communities, Dave, Talent, Vinny, and Mairead, but also to the participants that gave their time and their expertise throughout the process as well in all of the communities that we worked in. So again, just a real thank you for that. And I'm sure we will have questions coming in and look forward to answering those as they do.
Thanks very much to Mairead, Hannah and Maeve. It's really a fantastic example of how we can work with academic institutions while at the same time working with our communities and very much on a ground level. And I'd just like to add that it was great to see that in Cabra Finglas and in Mayo, the plans for projects going forward, so starting from August this year, very much incorporate the findings of the study. And it's great to see that value has been added and that we can really target in local authorities the knowledge that we've got from these sort of studies, where it can move in from being something theoretical to something that can be used in practice to deliver to our communities. We've just coming up to 11 o'clock now, and we'll be moving over into our breakout rooms. And as Gina said before, you've allocated those at the start when you registered, and you'll be in both rooms. You'll have support from a facilitator, Dr. Craig Smith and Dr. Stephen Behan, both from DCU, who've been involved previously in the studies. They'll be there to help you through the presentations and through feedback afterwards. So I'll now hand you over to the breakout rooms.
Okay, so everybody, the breakout rooms are going to open. I'm just going to stop the record for
Hi, everyone. You're all
Thank you.
welcome back. Hope you enjoyed your breakout session. I certainly enjoyed, I was at session 1, and I certainly got a strong message about the working with people in a rigid and agile way, and how that can benefit the delivery of the health literacy message to our communities. So I will now ask if Craig and Stephen can feedback the experiences of their sessions. So Craig has popped up first, so we'll ask Craig what his impressions were of the presentations and the questions that he had in the breakout session 1.
Yeah, thanks, Stephen. It's a difficult thing to do because obviously there's so much information in such a short period of time. So although I'll do my best to summarize it, I think for anyone who wants further detail, I think get in touch with the presenters. In breakout room 1, there's 3 fantastic presentations, but really, really valuable information. So by all means, get in touch directly, or the slides will be shared at the end of this webinar, I think, as well. So in terms of the breakout room 1, so it was all around approaches to supporting health literacy and well-being, and that was the overarching theme. So there was talks about kind of settings within the community, and Kath talked about using libraries as settings due to their accessibility and the ease of access in terms of removing lots of the barriers from the point of view of cost and stuff like that, and the fact that trusted materials can be found in there for people across the life course as well. So trusted materials in terms of health literacy, but general literacies as well, and we all know how closely linked they are. Kath also talked about the idea of moving away from the traditional single settings approach to moving towards a more super setting approach, which is really, really interesting, and basically allowing for health literacy support or development or materials to be where people are and meet people where they are, and place them where people will be. So places like the workplace, in the libraries, as was mentioned before, hospitals was another example that was used. So a really, really interesting approach to targeting health literacy and supporting health literacy is that kind of super setting approach, as Kat mentioned. Then Bridget Gagan from Westmeath County Council talked about the launch care communities in Westmeath and the initiatives or programs that are being run, and also spoke about the rapid areas, so revitalizing areas by planning, investment and developing so those areas. They talked about the trainer model as well, and how it's worked in Westmeath and in those rapid areas in particular. So how they've been used to deliver health literacy courses for adults, and also that social enterprise for QQI. So And what came through really clear to me was the importance of tailoring training to people's needs and moving away from that idea of that one size fits all. So really thinking of where that person in front of us is at and trying to ensure that we can tailor the training or the program to their needs as well. The Well Westmeath program was also discussed, and the areas of health that it's targeting, and how it's using that train the trainer model, and its potential impact, or the impact that it's having as well. And then finally, Deirdre Gallagher from Kildare and Wicklow ETB spoke around health literacy and digital health and digital skills as well, and details on the program that's being run there, and how it's being run, and the value and just the potential, the real impact that that's having on the ground in terms of people's lives as well. And that really came across strongly as well. So I will now pass to Stephen.
Thanks, Greg. And Dave, again, I will do my best to synopsize. We could have stayed in there for a couple of hours, I think, with so many questions, etc. So first up, we had Janice Morrissey from the Irish Heart Foundation, and Janice gave us a really, really whistle-stop tour of the amount of different initiatives that the IHF are doing, and especially specifically around the school and child interventions. And it was really great to see Janice speak about the various different collaborations they have with different higher education institutions in terms of developing these and rolling them out. Spoke about the importance of using vignettes as a tool. So vignettes is like a little key, a character or a person where they can run through scenarios, etc. And it was a really key tool for destigmatizing any of these behaviors, and it really, really got meant that they had real deep engagement by using these things. Really summed it up for me when she spoke about the co-design model as empowering the children and as empowering the people to give back, and that everyone's opinion counted. She had a really good quote from one of the participants. So really, really interesting to see that working across a broad area of initiatives. Next up, we had Susan O'Donnell from the IPU and Michelle O'Driscoll from UCC. Really interesting, speaking about pharmacy's role in terms of that health literacy piece, and from something just such a simple thing such as changing the labeling or enhancing the labeling, excuse me, on a prescription or on a bottle of medicine or whatever that may be, just to make it easy for people, right? To make it that it's not a barrier for accessing this type of thing. And even there's such a small thing, like in terms of the non-verbal communications coming out from behind the counter, to be that sort of human touch, to be that shoulder to shoulder, chatting someone and supporting them through. And I suppose we come at it from a research perspective an awful lot of the time, and it's very easy to forget about those small human touches that make all the difference, and that one-to-one connection. Last up then, we had Emily Marchant from Swansea University. So spoke an awful lot about her own experiences and work in Wales around the curriculum design and helping the schools from that sort of bottom-up approach in terms of designing a curriculum that really helped drive that health and well-being and that health literacy from a schools approach. And really interested in what they're doing in terms of having the survey data that they would collect with schools, that they can link it then into national data, so they have nearly comparisons immediately. And I hope I'm doing the explanation justice here, Emily, but really, really interesting, so that people can see where they're at compared to national standards, national measures, and that sort of joined up approach was really interesting to hear about, and I think really interesting to have a look at. And she really spoke an awful lot around the opportunities that are there around policies. So they spoke about policy have been identified as important in 2010, but potentially some of that had dropped off, and the importance of really driving it from the top down as well as the bottom up, so that you really get this sort of holistic approach to health literacy. And then I suppose we could have had 20, 30 questions if we had time, but just one of the questions and the comments and a bit of discussion around the importance of making sure the language we use, so that, like, someone made the point that mental health should be a key facet, and others came in to say, well, it is absolutely a key facet. And it's sometimes that the term when talking about health literacy is potentially a barrier in and of itself. So we need to be really, really careful about how we communicate that with stakeholders and with people on the ground. So That's it, I think, Dave, as best as we could do. But as I said, we could have stayed in there for hours.
Thanks very much to both Craig and Stephen. That was really excellent. And yes, I got that impression that the session I was in could have gone on for quite a while. There was a great discussion going on, and it was great to hear the feedback from both sessions about how people are important and how we should use all the assets in our communities, like pharmacists, schools, the libraries, and our own people as well, and all the services that are available, such as the ETBs, etc., that they really have. There really is a great community out there that can help advance health literacy in the country. So with their next part of the session of the webinar is we're going to have a panel discussion. And on the panel, we're going to have Helen, Hannah, Emily, and Vinny. Vinny, you haven't seen before this morning. Vinny O'Shea, who's National Coordinator for Healthy Ireland Local Government. So just to start off with, what I'll do is I'll ask each of them for their impressions of what's happened so far this morning and what they've heard, and what their main points it's brought to their attention are. So what I will do, I'll start with Helen, given that Helen's been waiting around the longest since she was one of our first speakers this morning. So Helen, how did you find the proceedings, and what are the key messages that are coming out to you?
Thanks, Dave. Yeah, I mean, I suppose I knew there was an awful lot happening, and we know that there is in health literacy. And what the challenge for me and the things I'm thinking of is how to bring all that together in a cohesive way where everyone is talking to everybody. We shouldn't be sort of at events, which is, and that is why I suppose with health literacy, and interesting further down, it would always once you mentioned when I work, Monsa Common from the National Adult Literacy Agency, for example, so NALA would have worked on this for 25 years nearly. They were back in 2000. And whenever we mentioned health literacy to health, they said, that's a literacy issue. And whenever you mentioned it to the literacy and the Department of Education, I know that's a health issue. So it did fall between two stools, didn't stop really good stuff happening. And I think today we've just heard the research was a really good setting, first of all, because we got to, and it's a great read. I agree with you, Hannah, there's a lot in it, but it is, really good, brings everything up to date. But then even more interesting, the breakout pieces were the practicalities. So I suppose for me now, my head is, it's in that spinning mode of how can we cohesively bring all the really good bits together and bring them forward. I mean, and that will be the job. That's part of the Adult Literacy for Life programme office has health literacy as one of our things, but there is one person which is my role, trying to go between policy, the department, and practice, which is the mammoth HSE, never mind the people, which they need their own response, which I'm so glad, obviously, Sláintecare Healthy Communities are there with your 19 people, and we have the 16 regional literacy coordinators as well. So I just think it's very exciting. I think there's lots of scope, but I do feel that we'll need to pull it together in some way, that at least if all of us were looking at something, we go, that's where you go to get that. And I'm not sure, and then academia put that in. I think it's all so good to have it and backed up, but we even need that a bit more. Who do you go to for which bits? And where the strengths lie. But look, lots of really good stuff. And I suppose that's the challenge now, is trying to take the really good pieces we've heard. So I'm hearing that people would like, if you go back to the people piece, need more programs, and we need them. We've heard about the school, we've heard about it needed in primary, secondary, and then in adult education and adult literacy world. But it's like what shape that should take. How do we really build co-design in, and how do we do monitoring and evaluation? Because I'm conscious of that too. We can't just be going off, and we need to have something to work towards and back in. So they would be my initial thoughts on it.
Thanks, Helen. That's really good. Emily, from shall we say the outsider view, someone looking into the country, what were your impressions?
Yeah, well, I mean, exactly that, to be honest. I think, speaking on behalf of what's happening in Wales, and what I spoke about in my breakout room was very much around the curriculum reform that we've had with the new curriculum for Wales that's been rolled out in school settings from September 2022, and health and wellbeing being one of these 6 areas of the curriculum now, which is really exciting because it allows schools to actually have the time and the space to prioritise health and wellbeing, and therefore health literacy to be integrated within that. And having read a lot around what's happening in Ireland in the education context, and I can't speak, in great detail about that. It's taken me about 5 years to get my head around the curriculum in Wales. But seeing that there's a new primary curriculum framework where wellbeing is one of the 5 core areas and one of 7 core competencies or something along those lines. I think there's hopefully a lot of lessons that we are currently learning in Wales, being so kind of new into this curriculum reform with health, wellbeing and health literacy, that we can hopefully share with you all in Ireland in terms of, hopefully addressing maybe some barriers and challenges and just that kind of knowledge sharing, I suppose. But actually the other way around, having heard so many fantastic presentations in my breakout room, but also in the earlier session as well, I think we can look a lot, we can learn a lot from each other. So, although we might be a few years down the line with health literacy and health and wellbeing in the curriculum, I really want to help and try and prioritise health literacy within policy in Wales and across, really just trying to prioritise it as a national kind of key outcome, really. And I think what's going on in Ireland is there's a lot that we can learn from. So yeah, for me, I think it's about trying to work more with other countries, and you don't necessarily have to redesign the wheel a lot of the time. I think there's fantastic practice going on, and we need more conversations.
Thanks very much, Emily. Hannah, what was your impressions of the feedback from your wonderful study?
Yeah, I mean, just to kind of echo the points there from Helen and Emily, I think sharing that best practice is really important. That collaborative, joined up approach. I mean, Helen mentioned it, sometimes we're falling between stools, and whether it's science, health, education, and health literacy really needs to sit across those different sectors and more. Often I think kind of, as Helen said, it's the resources to be able to do that. And we looked at that on a community level, right? So looking at those health literacy coordinators or those health literacy champions and needing those positions in West Mayo, but also needing that on a national level, and kind of to bring in Emily and kind of Kath's point, that international level as well, because there are opportunities for us sharing what we're doing. Talking about the curriculum is kind of one example, but also in terms of the work that's done with older adults as well in there. But enabling those to be tailored to our local contexts is really important.
Thanks very much, Hannah. Vinny, your impressions?
I suppose it reinforces everything that I thought already. So I'm delighted with and I was going in and out of each of the breakout sessions trying to get just some level of context on what was happening in each. So there's a couple of things just, I suppose, that I would say. Number one, I think Helen outlining the fact that nobody owns literacy from a health perspective is something that's positive. It's something that should be embraced, that whole complexity that nobody owns it. Sometimes though, the actual language we use can be problematic, as in health literacy brings you down a very, very specific focus. So health and well-being is, or even just well-being and well-being literacy might be an opportunity to avail of. And equally then from a policy perspective, I think that the National Wellbeing Framework offers opportunity here, because we're literally trying to improve the quality of life for people living in our country. And that means that adopting an approach where health literacy is important from the outset, from primary schools all the way up to lifespan approach, is a significant enabler, and also a significant health determinant preventative action. And I suppose the second thing I'd say then is it's just amazing each time we are involved in any of these sessions of webinars or attending conferences, just the whole area where everyone says it's data is the issue. And I think it was really, really interesting to hear Emily's piece of how they're able to integrate school data with national data sets. And I think for us here in this country, I think the National Curriculum Association are after developing the wellbeing curriculum for the primary cycle. And I think it offers us an opportunity to maybe start that journey that Emily was outlining. And just even from the conversations that we've had with some of our Wales colleagues, they're really, really interested in progressing health literacy across the lifespan, but particularly in those settings like the setting approach that Kat would have outlined. So it's all positive in relation to, it has a whole number of opportunities to be linked into communities that I think Bridget and Mairead and Talent would have outlined within their communities. And it's not just 19 people either, this in the Sláintecare health communities. There's another 31 people within the local authorities and many more.
Thanks very much, Vinny. A question has come from the floor. I think it's for Hannah. The needs of different cultures within our communities. Was there any points that emerged while you were doing the study or the engagements where there was extra needs or special needs needed for different cultural groups?
Yeah, and I mean, particularly, I think that question was referencing as well around language and echoing Vinny's point there around health and the connotations that has in terms of viewing it as a clinical issue. And that I think is reflected in Maeve's systematic review there, that found a lot of work that was done in different clinical populations because they have specific needs. In the findings that we did in the qualitative piece in both of the settings, but to take an example in terms of Finglas and Cabra, there were different groups there that had different language needs, different much wider issues going on beyond health literacy that need to be taken in consideration. And even in terms of our framing and suggesting that we were going to do a co-design workshop around health literacy, people were still not sure what health literacy actually was. And we need to do a much better job in communicating what that is and whether that's important to people and why it's important to people.
Thanks very much, Hannah. I have a question here for Helen. We've talked quite a bit about just the health literacy, and there's been some references to the other literacies, such as digital numeracy, financial. Do you see there have been opportunities for similar community-based approaches to assessing and delivering health literacy needs, and as you would with the other literacies? And is there any work that could possibly be done in parallel? Sorry, you're on mute, Helen.
Sorry, Dave. Yeah, so in terms of, and we didn't get in too much on the statistical side today, but I mean, people are probably aware in general from the old statistics, but there's a new survey, actually, a new big CSO survey program for international assessment of adult competencies, big acronym PIAC, due out towards the end of this year, which is really exciting to see what the figures are. But 1 in 6 adults, the current stats, do struggle with reading and understanding everyday information. 1 in 4 would struggle with numeracy, and even worse, it's 42%. So 4 in 10 with digital skills. So I suppose one of the key pieces to say is that, you know, and that equates to roughly around 500,000 adults, we'd say, just on the reading sphere. There are about 70,000 adults accessing, you know, the free, confidential, highly experienced and trained education training boards, adult literacy services around the country. So I think that's, so first of all, people are going in where it's there. Now, that's not everybody. We said there's 500,000, we still a lot of people to serve. The issue then is, how do we get people in and why do people come back in? And I suppose that's where the things like when you talk about, and I'm really interested around language, health and well-being, it's all very linked in as well. And somebody in our group as well talked about mental health, which again, where people struggle with these skills and they can't access online banking. You know, they're struggling with maybe a new health condition like diabetes, they can't read it and they feel excluded from their healthcare. This affects your mental health, and it all is very much interlinked. So I think in yes and no in one sense. Absolutely yes, but people need to then tell us what they want. This goes back to co-design then, doesn't it? What do I want as an individual to upskill on? You know, so if I love the idea of responding to people's needs where they're at. So for example, I've worked a bit with some of the hospitals. So Tala Hospital have the pain clinic, or the diabetes clinic. Let's get people where they're at in the health world. Now, the health and well-being is a bit broader, and I think that's where the ETBs and the Sláintecare health communities and all of the literacy stuff we can interlink. But I do think the research coming out, and there is a new research report the Department of Health will hopefully be launching in October, which is the Personal Health Literacy Survey, the EU survey, that says about 30%, 28% of Irish adults have needs. The health literacy is linked to financial literacy. I thought that was really interesting. So where people have health literacy needs, they often also have financial needs. Numeracy obviously linked into that as well. And then the digital justice coming at us all. And in the health world and in the policy side, I don't know what it's like, Emily, over in Wales, but the big hot topic and news here in health literacy world is digital health literacy. So, you know, we need, that's coming at us. We're all getting e-health records. A lot of the stuff is moving online. So I definitely think, Dave, we can, it all can be interlinked in, but we need to work with current existing services that are there for people who want something very intensive, go in and build up. And then what the communities can offer is that bridge maybe to get them in initially. What are you coming in for? Health and wellbeing, love it, grand, and then let's move you on into something. So there's lots of scope.
Grant. So there are bridges, you can bridge from one to the other, and give it's a whole of person's life that you're dealing with and improving. Question sort of for Hannah, and sort of the way you approached using the double diamond approach in Mayo and in Dublin. Do you think that might have uses in other areas of consultation or research with communities? Is it an adaptable tool, do you think?
Absolutely, and I think co-design has to be, and to kind of take Helen's phrase there, to meet people where they're at. And I would be the first to point out some of the limitations of our approach in terms of meeting and recruiting those people to be involved in that process. But it has been used previously in other kind of healthcare and social settings. I've used it in a physical activity context, in a physical literacy context. And as I kind of described, we adapted it in terms of not closing that second double diamond approach within there, but kind of things to be mindful. If you were looking to kind of adopt that approach, I would definitely suggest being really observant of the people that you are attending, kind of recruiting to attend those sessions in terms of the purpose of your workshop and the purpose of your project. So in this case, where we were really interested to get the lived experience of community members, we had a lot of community members in the room. In other places where you might be targeting to look at policymakers, you might be looking at inviting different participants to that meeting, and you could adopt it to those different audiences in how you do it, and how you do it. As I spoke to, the facilitators are really key in sharing that power dynamics, especially when you move to those mixed stakeholder groups. Yeah. It's really important that everybody feels that they do have the expertise and they feel comfortable and confident in sharing that. And then finally, do not cheap out on the stickers that you use for the Democracy. The first workshop we used were incredibly cheap and star-based stickers that people found really fiddly to use. So definitely go and get your nice circle dots.
Great practical advice as well. Thanks, Hannah. Emily, in terms of advice, Wales are more advanced, I think, in their health literacy approach than Ireland at the moment. And your approach to data and ownership seems to be a bit more developed. Is there any advice that you would give us here in Ireland as to how we might progress as a potential best practice in terms of data collection, ownership, and who owns or how we share ownership of health literacy?
Yeah, great question. I think in terms of what we have in Wales, we're in quite a unique position, and actually for a small country, quite world leading with the what I spoke about in my breakout room, which is the SAIL data bank, which collects routinely collected anonymized electronic records for the population. So that includes everything from birth records, all hospital data, GP admissions, social care data, crime, education, and absolutely everything. But then also what I co-lead with my colleague at Swansea University around collecting kind of school level health and wellbeing data. But what I tried to emphasize in the breakout room is the importance of data sharing. And I think too often as researchers, you know, our sole purpose is collecting data, publish papers, and actually forgetting that data is powerful and it's a tool to improve outcomes for people. So I think my main piece of advice really is about the importance of data sharing, working with people you're collecting data on and trying to improve outcomes for and impact. And part of that, you know, yeah, it's great having all of this quantitative, you know, indicators of health, wellbeing, health literacy, but also the importance of qualitative data working with, like I said in the breakout room again, but working with schools, working with teachers, speaking to them. I think it's the luck of the Irish, because I've just had an email saying I've had a small study approved, which is actually just about that. So it's a qualitative study to work with schools to find out areas of best practice around health and wellbeing curriculum design. So yeah, I think part of it is the importance of data sharing and collecting that quantitative, you know, outcome-based data, but also qualitative, finding out perspectives of schools or of communities, you know, and then sharing and kind of tailoring what we do based on the perspectives of those that we're trying to impact.
Thanks very much, Emily. I'm afraid that we're sort of running short of time now, and unfortunately, I could keep going this panel discussion for another hour or so, I'd say, if we wanted to, quite easily. But I would thank you all sincerely. It's been really good. So just to sort of wrap up, given that I've overrun, if I could just share my screen with some contact details, etc., for what we've been doing here. Just one second. So in addition to the webinar we've just had here, we plan 2 future events on different themes. So we have one planned with a working title of Enabling Wellbeing Environments for the 21st of October, and another one for the 18th of November, which has a working title of Preventative Approaches to Support Community Wellbeing. So again, anyone, you're all welcome to come to those events in the future. We'll publicize them on our website and on our social media as we have more detail. I have this slide here. It's got our own contact details. There are also contact details for the Sláintecare LDOs in the 19 Sláintecare areas, but also for our Healthy City and Counties coordinators, which haven't had much discussion here. Every single local authority in Ireland has got a Healthy Ireland City and County coordinator who've got a more general role than in health and wellbeing delivery within their local authority. So feel free to contact any of those if you've got any questions or suggestions on this health literacy, or how you might like to contribute in your area or know more about in your area. They're on our website. They're hilocalgovernment.ie. And finally, I really want to thank everyone who turned up and everyone who participated, and more especially all our contributors here today. We've had 14 contributors from 11 different organizations, and I would really greatly indebted to them all for their contributions and the hard work they've put into today. It's really very much appreciated. Thank you all. So we will make all our all the presentations, etc., available on our website to download in the coming days. It won't be for a day or two. And also the recording of this webinar will also be made available for anyone that wants to look back or wants to share with colleagues. So just again to say thank you all for attending, and hopefully you'll see you at future webinars for Healthy Ireland Local Government. Goodbye now.